Hello, and welcome to the 2020 Komen Virtual MBC Impact Series. I'm Pam Cole, Director of the Komen, North Carolina Triangle to the Coast Metastatic Breast Cancer Collaborative Research Initiative. The Komen NCTC team and I are so proud to be hosting this session on what's driving your MBC as the second part of the virtual MBC Impact Series in partnership with Komen Puget Sound, Komen Charlotte, and Komen Atlanta. In a normal year, we would be meeting in Chapel Hill today for our 5th annual Young Researchers Roundtable Breakfast, the first event in our Finding Solutions research series here in the Triangle in North Carolina. The breakfast has been a powerful opportunity for metastatic breast cancer patients, our caregivers, breast cancer researchers, and advocates to share their perspectives on pressing topics you'll hear about today in this MBC Impact Series. With the challenges brought about by COVID-19, we are grateful to still be able to meet and to continue these very important conversations. I'd like to thank our sponsors, Seattle Genetics, Pfizer, Lilly Oncology, and Walgreens for their support and making this web series possible. We all know that MBC is personal to many of you in attendance, and it's certainly personal to me. In 2009, I was diagnosed with stage 1 estrogen positive breast cancer, less than a centimeter, no lymph node involvement, and an oncotype of 6. I was a poster child for early detection, and we were optimistic that with my oncotype of 6, that a recurrence of breast cancer was not going to happen. I had a very low risk of that. I did a lumpectomy, I did a radiation treatment, a whole round of radiation, and I did 5 years of endocrine therapy. I'm sure many of you listening today went through very similar treatment. At the end of my 5-year endocrine treatment, I was told that I was cured and that breast cancer was in my rear view mirror. And we had great celebrations with friends and family knowing that breast cancer was behind me. However, 3 years later on my annual mammogram, there was something suspicious in the same breast. And even though everyone kept saying, oh, it's nothing, but we need to do another ultrasound, we need to do a biopsy. And it was discovered that I had a breast cancer recurrence in the same breast. And although everyone believed strongly that it was just a recurrence, because I had radiation in that breast before, I still needed to have a mastectomy, which I did. And based on some inconclusive results in the pathology, it became clear to me that maybe we needed to go further and have a PET scan. Although the doctors kept saying, you don't need a PET scan, you don't need a PET scan, but I work at Komen and I knew a few things, and I personally advocated for myself, and after about 6 weeks I finally got approval to have the PET scan. The PET scan came back with 2 suspicious areas and that required a biopsy, which is never a good thing, as many of you know. And because of where those tumors were, I was put to sleep. And when I was in recovery, my husband and I were in recovery waiting. And it was 6:30 at night, and I saw my medical oncologist and my radiation oncologist walking through the door at 6:30 at night. And I looked at my husband and said, this is not going to be a good result. And I was correct. I was diagnosed with stage 4 metastatic breast cancer, estrogen positive, and was immediately put on oral chemo drugs. And as many of you listening and watching know, that is a moment that will change your life forever once you are diagnosed with stage 4 metastatic breast cancer. But we do have hope. All of us have hope, and that hope is research, and that gives me and my family hope every day, as do the incredible women that we will hear from in just a few minutes. We are so lucky to have such passionate, brilliant people working to find treatments and cures for those of us who are living with metastatic disease. If you are active on social media, please share your thoughts and takeaways from today's series. Use hashtags MBC Impact and Finding Solutions. First, we'll hear from Dr. Carrie Anders. Dr. Anders is the medical director of the Brain and Spine Metastasis Program at Duke Cancer Institute and a professor of medicine at Duke University School of Medicine. She has served as the principal investigator on numerous research grants, including immunotherapy to treat triple-negative breast cancer brain metastasis, molecular dissection, and immune characterization in breast cancer brain metastasis, and in vitro fertilization outcomes in women diagnosed with cancer. We are so delighted to have Dr. Anders with us today. So many of us are so concerned about brain metastasis. Dr. Anders, your work is so important and inspiring to all of us. Please welcome Dr. Carrie Anders to the screen.
Hello, everyone. My name is Carrie Anders, and I am a breast medical oncologist at the Duke Cancer Institute. And it is such a pleasure to be here with you today remotely. I certainly wish it was in person for the Komen Impact series. Today, I'm going to be talking with you about what is driving your metastatic breast cancer and why does breast cancer develop resistance mechanisms. So just briefly, my disclosures. So just to give you an overview of what we're going to cover over the next 20 minutes, I wanted to first start with the importance of receptor status in breast cancer and how it impacts our decisions in treatment. We'll then spend some time talking about mechanisms for resistance in metastatic breast cancer, as well as the importance and integration of next generation sequencing, both from tumor and from blood, and what's going on in the research space to help us understand the biology of metastatic breast cancer to provide best care. So I think it's very well known to this group that breast cancer is no longer viewed as a single disease process. But in fact, as we're making decisions in the clinic, receptor status is highly important. And you'll see here that the large majority of breast cancers express the estrogen and progesterone receptor and are negative for the HER2 oncogene. We do have about 30% of breast cancers that express HER2, as well as about 20% of breast cancers who lack expression, whose tumors lack expression of the estrogen receptor, the progesterone receptor, and HER2, which is deemed triple negative breast cancer. But as we've learned more and more about the biology of breast cancer, these three subtypes are just the very beginning of what we're currently using in the clinic to help with our treatment decision makings. And we're now moving into an era where mutations in other genes are also very important as we're making treatment decisions. So here is our current treatment algorithm endorsed by the National Comprehensive Cancer Network. And you can see for providers who are treating patients with metastatic breast cancer, we have very clear guidance. For our patients who develop recurrent or stage 4 breast cancer, we first look to see if bone disease is present, and that helps us to decide whether or not a bone-directed agent would be helpful in their care. Among many other factors, we also look at the subtype of breast cancer. And here you can see just what we spoke of before: estrogen and progesterone receptor positive breast cancer, HER2 negative goes down one treatment algorithm. We also have hormone receptor positive, HER2 positive, hormone receptor negative, HER2 positive, and again, the triple negative subtype, which helps guide our decision making. Treatment decisions, as we discussed, are highly dependent on this subtype, as well as many other factors, including patient's baseline health, patient's preference, and other exposures to breast cancer treatments in the past, if applicable. But you'll see, and I won't go through this entire list in full detail, but in each of the buckets or subtypes of breast cancer, we have very clear guidance on what therapies we should match with subtype. So for instance, in ER-positive, HER2-negative breast cancer, endocrine therapy or therapies that block estrogen signaling are the mainstay. We now have a whole host of biologic therapies that have emerged over the past decade to target pathways that are active in hormone receptor-positive breast cancer as well. In the HER2-positive space, HER2-directed therapies are recommended, and you can see this list is quite long and only continues to grow, and essentially involves antibody therapies that target HER2 as well as small molecules that work on the inside of breast cancer cells and target HER2 signaling from the intracellular compartment. And then finally, in triple negative disease, we do rely on chemotherapy as one of our backbones. But we've also seen the emergence of immunotherapies in this subtype of breast cancer, as well as antibody drug conjugates. And we'll also be talking about the impact of BRCA mutations on the care of patients with breast cancer, particularly with the class of drugs PARP inhibitors. So to illustrate decisions and treatment as well as resistant mechanisms, I wanted to go through a case study, as I find that in my learning has been the best way for me to understand these highly complex concepts. So I wanted to present a case of a 42-year-old female who presented with an abnormal mammogram and was found to have a biopsy-proven right-sided invasive ductal carcinoma of the breast. Estrogen receptor positive, progesterone receptor positive, and HER2 negative. At surgery, which consisted of a lumpectomy and sentinel lymph node biopsy, she was found to have a primary tumor a little over 3 centimeters and 5 positive lymph nodes. At the time of diagnosis, based on her age and her family history, she underwent genetic testing and was found to have an alteration or mutation in the BRCA2 gene. Based on her positive lymph nodes at diagnosis, staging was performed with a CT and a bone scan, and she was found to have bone metastasis, which were biopsy proven, also hormone receptor positive and HER2 negative. She moved on to our frontline therapy with ovarian suppression, an aromatase inhibitor, and a CDK4/6 inhibitor with a bone-directed therapy. This was very well tolerated. She returned to practicing law and raising her 2 children. 2.5 years later, on her current therapy, she developed progression with 2 new liver lesions and progression in some of her known bone metastasis as well as new bone metastasis. So you decide together that a biopsy of a liver lesion is recommended to determine next steps in her care. And the question would be, why would another biopsy be indicated in this setting? So some of the considerations might include the fact that the receptor status may have changed, and we'll talk about this a bit. The other is we now have tools that'll help us better understand resistance mechanisms to current therapy, as she's been on the same treatment for over 2 years, which could guide next steps in her care. And this would really help together decide the next treatment options for systemic therapy of her metastatic breast cancer in the second-line setting. So what is receptor discordance? Well, discordance, as defined by Webster's, is essentially the state of not agreeing or being out of harmony or varying. In the setting of breast oncology, what this has also been termed as receptor shift or tumor heterogeneity. And essentially what this means is that we know breast cancers are made of multiple subclones, some of which are estrogen receptor positive and dominate, some that are HER2 positive and dominate, and some that lack all 3. Throughout the course of the metastatic progression and from the time of a primary breast cancer diagnosis to recurrence, we can see changes in this receptor status. Essentially 15% of the time, we'll see a change in the estrogen receptor. It may drop out or it may add back in. The other important finding is HER2. And approximately 15 to 20% of the time, we can see a change in HER2. And I would say more commonly that in the course of a patient's metastatic breast cancer journey, it's more common to lose estrogen receptor expression and gain HER2 expression. And this just has to do with the nature of the breast cancer progression and which clones begin to emerge under treatment pressures. So how did tumors become resistant to certain therapies? And here I wanted to focus in on CDK4/6 inhibitors. And this was data that was presented at the 2019 ASCO meeting, which was a fascinating analysis of patients' tumors prior to and after treatment with CDK4/6 inhibitors. This was part of a study at Memorial Sloan Kettering called the IMPACT study. And essentially, and I won't go through all the technical details, but patients' tumors prior to and following exposure or progression of a CDK inhibitor underwent an integrated genomic analysis through a very sophisticated pipeline to really identify what genes and pathways were altered that allowed the cancer cells to grow in the face of CDK4/6 inhibitors. And essentially, the investigators found three main themes. One, not surprisingly, they saw that the targets, the CDK machinery itself, hyperactivated itself. The second finding that they found is that the cancer cells adapted by losing one of their targets, which essentially is the retinoblastoma 1 gene. And then finally, the cancer cells adapted to find bypass mechanisms. Instead of relying on CDK4/6, the tumor cells started to rely on alternate pathways like cyclin E1. And you can see in yellow that there are many investigations in the laboratory and in the clinic to try to overcome these areas of resistance. So how do we determine if these resistance pathways are active? And I will say that this is this is a list of many of the next generation sequencing platforms, and I'm sure I've forgotten some of them here, but just an overview of some of the many tools that we have in our clinic to send tumors and liquid biopsies, which essentially are tumor cells in circulation, to look at the changes in the tumor in response to therapy over time. And these are tools that I have to say I didn't train with. These are new tools that we now have in our clinic, and I feel so much more informed when I'm talking with patients about their disease process with the results of these tools in hand. So back to our patient's case, a liver biopsy was performed and next generation sequencing was performed on this liver biopsy. And several things were found. So one, a resistance mechanism was identified where the tumor had actually lost expression of the retinoblastoma gene. And we just talked about the fact that this is known to be one of the resistance mechanisms in response to prolonged CDK4/6 exposure. The other thing we determined was the BRCA2 mutation. We knew that this was present in the germline, and this was also our germline DNA in every cell in the patient's body. But we also were reminded that this is a therapeutic target for this patient's individual tumor. So together, the decision was made to move forward with treatment with a PARP inhibitor. And here, essentially, the way PARP inhibitors work is by blocking DNA damage repair in cancer cells, resulting in cancer cell death. And tumor cells that have mutations in the BRCA gene are highly susceptible to PARP inhibitor therapy. And in fact, we have FDA approval of PARP inhibitors in this setting. So just a few things to know about BRCA gene mutations. One is that not all breast cancer is the result of an inherited gene mutation. And in fact, only 5 to 10% of all breast cancers are the result of a mutation that a parent would have passed down to a child. And here are some examples that we commonly look at in the clinic: BRCA1, BRCA2, PALB2, the list goes on and on. The panel is well over 20 genes now. But we do know in a patient who's known to have a BRCA1 or 2 mutation that this does open up the therapeutic option for a PARP inhibitor during the course of their treatment. I know this can seem quite confusing, and you may be thinking about your own care, so I would certainly encourage individuals to seek guidance from their physicians if they have questions about their own individual BRCA status. So how does this work in the setting of treatment with a PARP inhibitor? And you'll see in the top panel that's in the setting where patients do not have a BRCA mutation, or essentially a sporadic cancer, two sporadic events are needed within a gene to develop a tumor. In inherited cancer, a patient is born with one mutation in the BRCA gene, and the other gene is normal. When a second hit or a second mutation occurs in the gene that was previously unaffected, a tumor develops. And in this case, treatment with a PARP inhibitor is effective. Interestingly, we have learned that under pressure of PARP inhibition, that the second gene hit can actually revert itself to normal function. And this is one of the ways that resistance to PARP inhibitors can occur. And this is something that's being explored in the laboratory, in the clinical space, essentially knowing that one of the ways that patients' tumors become resistant to PARP inhibitors is when the BRCA gene essentially turns its function back on under selective pressure, making the sensitivity to the PARP inhibitor less profound, meaning that it's probably time to move forward with the next therapy. So in terms of research, you know, all of this data was founded in research. And this is really going to be key to the discoveries that have already been made and discoveries to be made in the future. And just as I said earlier, you know, when I was training to practice oncology, many of these discoveries had yet to be made. So I'm very excited about the next set of discoveries that we'll see over the next decade. And this is an example of one of the coordinated efforts, the Aurora US multi-platform analysis of primary tumors matched to metastatic breast tumors to try to understand what is driving the biology of metastatic breast cancer. This is a joint venture between the Breast Cancer Research Foundation and the Translational Breast Cancer Research Consortium, really illustrating how multiple individuals can come together to really tackle this problem of metastatic breast cancer and help us understand what are the next discoveries yet to be made to help our patients in the future. So with that, just a couple concluding remarks and future directions. You know, I hope that I've illustrated that breast cancer subtype is integral to our therapeutic decision making, and subtype can change over time. Also, that the knowledge of genetic alterations in breast cancer are now critical to us in the clinic as we're selecting our best therapies, and next generation sequencing is here to stay. I will say that proactive biopsy and sequencing of tumors, whether or not it's through the tumor tissue itself or circulation, is key. And this will continue to help us understand resistance mechanisms and make the best treatment decisions for our patients moving forward. And I look forward to the many research discoveries ahead of us to continue along this trend. So with that, I would like to thank the organizers for the opportunity to present and look forward to the discussion during the question and answer session. Thank you very much.
Thank you, Dr. Anders. Your incredible work and leadership in this space. We are so grateful for the work and the passion that you provide every day. And we look forward to hearing your responses to the live Q&A in a few minutes. Now we'll hear from Dr. Lisa Carey of UNC Lineberger Comprehensive Cancer Center. Dr. Carey is the Richardson and Marilyn Jacobs Pryor Distinguished Professor in Breast Cancer Research and Deputy Director of Clinical Sciences at the University of North Carolina at Chapel Hill. She is an expert in triple negative breast cancer and led the first trial looking at new drug regimen in this breast cancer subtype. Her tumor donation program, which we will hear more about today, has contributed novel information regarding the genetic differences between the original primary breast cancer and the metastasis in distant organs, obviously something all of us care very much about. Dr. Carey is a member of the Susan G. Komen Scientific Advisory Board and on the Board of Directors of the American Society of Clinical Oncology. Please join me in welcoming Dr. Lisa Carey to the screen.
Cancer, either de novo, meaning from the very beginning at diagnosis, or later on as recurrent disease, is in fact one of our major challenges, where our goals are to maximize control and longevity, quality of life, and we hope someday cure. So I want to make a plea for the differentiation between pubs and silos. And that is, as a researcher, it's incredibly important that we work together and that we function in pubs. And this is a picture of the Eagle Pub, which is where Watson of Watson and Crick fame first discussed the double helix of DNA. He didn't do it in a small room. He didn't do it in a conference center. He did it in a pub. And he did it with his colleagues and his friends. And that generated more ideas and more research, and that's how we should be functioning, as opposed to the more traditional, you go and work in your lab with your own lab mates and that's all you do. So I think the truth is that everything we do is gotten increasingly complicated, and unless we learn to function effectively in pubs, or the research versions of those, maybe without the beer, we're not going to get nearly as quickly or as effectively to where we need to be. So here's a little bit of a cartoon that illustrates where things were when I started doing research in metastasis and in breast cancer, which is the old adage about the different scientists, and they all come across a different part of an elephant, and they can't see the other parts of the elephant. So one thinks it's a rope, one thinks it's a wall, one thinks it's a spear or a snake. And the truth is that we need to have a way to comprehensively look at a tumor in a much better way than just individually coming at it from our own perspective. So fortunately, that's where collaborative and integrative science has come to the rescue over the last, really it's the 10, 20 years only that we've been able to do comprehensive evaluations. So I think it's important to start by saying that cancers all have mutations that alter gene functions. That's a nature of cancer. It's a hallmark of cancer. And the ability to identify not just mutations one at a time, but actually studying all of them in concert is what's called genomics. And that is a common phrase, you'll hear about it. There's a lot of omics. There's proteomics that look at protein. There's transcriptomics that looks at RNA. Genomics is technically DNA, but it is used in a general sense to talk about looking at how the genetic aberrations of a tumor and increasingly of the area around the tumor and interacting with the tumor work together to control tumor behavior. It lets us identify clusters and patterns of genetic and other alterations that are driving how a cancer is behaving. So the kind of technology that came through, I'm showing here a picture of my scientific colleague, Chuck Peru, who was instrumental in developing the technology that let us start to actually look at the expression of genes in toto across an entire tumor rather than one at a time. And that way we can query breast cancer cells, the local immune cells, all of these other things in an integrated fashion. Now, the truth is, this sounds like, oh, it's just doing something that you were doing one at a time, and you now do it 1,000 times. But the truth is, what you get out of these sorts of analyses is this kind of data, which are just impossible. But through the value of increasingly complicated computer algorithms and analytics, we actually now have excellent tools and computer scientists who can make some sense of this and give us a feeling for why a cancer is acting the way it is. And as I just alluded to, we have to also acknowledge that the tumor itself is only part of the equation. So in the left, I have the tumor, and the tumor in truth, as Dr. Anders was just outlining, has hundreds or even thousands of potentially targetable aberrations, depending on how smart we get over time. But the truth is that there's also the microenvironment around the tumor. And we highlight currently the immune cells, because the immune cells in and around the tumor definitely affect the way the tumor behaves and also themselves can be targetable. But increasingly, there will be other elements around the tumor that are looking like they may be important also. But for the time being, we focus on both the tumor and the microenvironment with a focus on immune cells. Now, using the tools that we now have in our toolbox, we actually can look at these separately. You can pull out tumor cells one by one and look at them one by one and see how they differ from each other. You can also pull out the immune cells, or you can look at the interaction of these two. And to be honest, at the moment, the interaction is kind of more interesting than each one alone. So the other problem, which is getting us towards the issue that we're going to have to address with metastasis, is the mutability of cancer. So cancer cells are inherently unstable. They change over time. They change under the pressure of drugs that we give them. And why does this matter? And sort of the obvious reason is, we have in the US about 40,000 people per year who die of metastatic breast cancer. And a classic story of this breast cancer might be an original breast cancer that develops in 2016, is diagnosed, is treated, and then comes back in the liver, the brain, wherever in 2020. Now, oftentimes we have that 2016 tumor for testing in what we call precision medicine. But of course, the 2016 tumor is not the problem. The 2020 tumors are the problem. And I think Dr. Anders was already starting to lead you down the reason that we think that it's important that we actually are much more proactive about looking at the 2020 tumors and figuring out how they work. The other thing that's worth noting is, of course, metastatic disease is not a binary uniform function. And so I have two vignettes. You have a 40-year, this actually came from the Aurora study that Dr. Anders mentioned that I'll talk about in a second. A 40-year-old woman treated for a hormone receptor positive HER2 negative cancer. 7 years after her diagnosis, when she was on no therapy, her cancer recurred in bones and her chest wall. It stayed indolent, it stayed asymptomatic through nearly 20 more years of treatment before it became aggressive and she passed away 24 years later. So conversely, we had a 57-year-old woman treated for a similarly hormone receptor positive HER2 negative breast cancer 9 months after her diagnosis. It recurred in liver and bones. Nothing worked for more than 4 months, and she passed away within approximately a year, year and a half after her recurrence at 59. Now, these are simply not the same disease, right? They are not, we don't think of them the same. We have clearly failed in our goals of therapy for the one on the right. And while not the success we would like it to be, certainly the one on the patient on the left did much better and had a much better course. And how do we want to be able to turn more into the left-hand case and less in the right-hand case, and then ultimately, hopefully, to cure them. So cancers evolve, and this is a cartoon that kind of illustrates what cancers can do. There is an evolution over time. As you can see, cancers derive from a normal breast, and you start to develop cancer cells, and oftentimes the cancer cells have some time before they are diagnosed. That's always true, and usually on orders of several years. And then even after they're diagnosed, you have both chronologic time and you have biologic time. And so the cancers evolve because of that mutability that I mentioned earlier. They are unstable, they develop new mutations, new genetic aberrations, whether they be a mutation or not, they are still different. And you also give them drugs frequently that can push them in one direction or another. And the truth is that the cancer at diagnosis with the first arrow on the left may or may not be the same as the one on the right. And usually, at least in subtle ways, they are not the same. And I think one of the things that's become increasingly important is not, we look at, with a metastasis, we do redo receptors. We do redo the things that we know are therapeutically germane. But the truth is that we're finding more and more targetable things. And the truth is that also cancer therapy has become very complicated, and a myriad of additional drugs have been developed many of these are targeted. In fact, most of them are targeted. And you need to figure out what genes are in fact important. And it may be important in the same aberration, may be important in one person's tumor and not in another person's tumor. How do you figure that out? So among the tools in the toolbox that we have with our computer scientist friends is to looking at the RNA, which is the output, to see what the DNA changes are doing and whether they're affecting the genes around them. And what I've called that is sort of looking at the ripple effect. So if you have a genetic abnormality and it doesn't do anything, then it probably isn't very important. On the other hand, the same genetic abnormality that starts to cause derangement in the behavior of all the genes around it, that's probably important. And theoretically, if you target that one, it may actually make a difference. Where if you target the first one, it wasn't doing anything, so it probably doesn't matter. So Pam earlier mentioned the UNC breast tumor donation program, which I'm going to briefly talk about. It's a pilot program, essentially. It was about 65 UNC patients so far, in which we did detailed biology, looking at DNA, RNA, proteins, et cetera, on multiple metastases, and whenever we could get it on the original breast cancer. So there's a few findings that are I think, important and illustrate the value and the worth of really investing in trying to look at the metastases in addition to the primary breast cancer. So the first is that individual tumors can contain biologically different cancers. And I have here in the red outline the subclones that are all color-coded. And if you look, you can see that there's different clones and a little bit of a different mutational spectrum in the liver metastasis, the rib metastasis, the lung, the brain, the kidney, and the original cancer. It's also worth noting that if you look down on the bottom of this tree, the original cancer actually has several of the clones. If you knew what to look for, you could find them. Although, to be honest, you have to know what you're looking for. And here's an example of one of those patients and illustrating the complexity of the disease that can happen. This is one woman's breast cancer, and what we found was 2 genetically distinct cancers. Now, that little graph on the right-hand side looks more complicated than it is. What it basically is a depiction of the DNA abnormalities in the original breast cancer and the DNA abnormalities in one of her metastases. In this case, it was the lung metastasis as an example. And you can see that there's some overlapping, those are the green ones, in a subcancer that's labeled number 1. But there was also a second cancer, the subcancer number 2, that was recapitulated in both the lung cancer and the original breast cancer. And to be honest, was there in both places. And you might not know about both of these, depending on what kind of tests you had done on the original cancer or even on the metastases. But in truth, both cancers in her case were seen in the original cancer, her liver, lung, and her brain metastases. The second finding that we had, and these are sort of intriguing things that lead us in a direction for how to try and approach the problem of figuring out how metastases work and how you can go backwards and figure out how to prevent it. And that's at numbers rule, is what I've called this. We do a lot of gene mutational analyses, which are mistakes in the gene code. But in truth, if you see here what we call drivers, so that the genes that cause the ripple effect, we call driver genes. If they didn't cause a ripple effect, could still be a mutation, we call them passengers. So the driver abnormalities using that ripple effect tool showed that while there were quite a few mutations that were found, those are shown in the red, in truth, the more important ones and the more frequent errors that caused ripples were actually errors in the number of genes. The genes themselves were not mutated, so they were technically normal, but there were either too many of them or too few of them compared to normal. And that's actually something that we should keep in mind, because when we do DNA sequencing, you may find something to treat, but a lot of times in metastatic breast cancer, the problem may not be with mutations, but with either too much or too few of a particular gene. And the third one was that we found a lot of genetic abnormalities. And I gave you a couple of examples where they were shared, but as I showed you in that very first tree, and this shown here, they could be different. So the liver one being different from the lung one, being different from the rib and the kidney, that's a problem for precision medicine as we think of it today. And you can see quite a few of these things that are highlighted in red. The highest number of the genetic abnormalities, just purely as findings, was actually only found in one metastasis. But again, if you control for those that seem to matter and had the ripple effect, then you start to see that most of them were found in multiple places. And that's probably why they were showing ripple effects. That's why they're in all these places. So I think we have to be careful that just identifying genetic abnormalities may not mean that they're important. Most of the important ones are more, we can find them in multiple places, and we have to be able to identify them better than we do right now, because sometimes we end up with just happenstance findings without actually making sure that they are important. And this is good news for precision medicine, because as we get better at identifying them, those are the kind of things that you can target because they are clearly important. So the Aurora US Metastasis Project, the goal here, and Dr. Anders mentioned it earlier, it's run through members of the Translational Breast Cancer Research Consortium, or TBCRC. The goal is to identify molecular features of metastatic development and progression. And it's basically similar to what I was just showing you that was done just at UNC, but it's a comprehensive analysis of DNA, RNA, proteins, et cetera. We did a pilot that was mostly UNC patients, but started to incorporate Dana-Farber, University of Pittsburgh, Mayo, Hopkins, Georgetown, and others. And the next study is actually going to include many more institutions around the country. And basically, it's looking at the original breast cancer, looking at the metastasis, and trying to see how are they different. And I show you in the red here some of the differences that came out in the first pilot analysis, which was you see a little more of what's called a molecular subtype called HER2 enriched, which may relate to the HER2 pathway becoming more important as one moves into metastasis. That might or might not be targetable. I think that's actually something we're studying right now. They're faster growing. They are less similar to the original breast cells, that probably goes without saying, and they actually have less immune cell activation. There's a little encouragement there, because that may mean that immunotherapy may actually have more of a chance of working in early breast cancer to prevent metastasis than in treating the metastasis, where there's a clear effect, but we're still working on trying to get it to be better. So this project is going to include metastatic samples paired with the original breast cancer from hundreds of patients. So I talked to you about, the handful that we did simply at UNC in our pilot that was Komen supported and allowed us to kind of pressure test this approach in the prospective project, the prospective trial that has started about 6 months ago. Is going to have hundreds of patients, which give us much more power to really identify things. So what would I call the future for metastatic research? So targetable genetic abnormalities in cancer, I would call them, they're like needles in a haystack because there are so many of them. There's so many genetic abnormalities. Finding the targetable ones can be quite complicated. But I'm really encouraged that working with our scientific colleagues, we're developing the tools to figure out where and what kind of needles they are, both in the original cancer so that we can tailor the original therapy to try and prevent metastasis, but also in the metastasis to tailor the metastatic therapy to be more effective and hopefully turn patients more into the indolent patient who lived for decades after her diagnosis and quite well. So I'm going to close by commenting that it's not lost on me. I trained at Hopkins where I was for a long time. The guy up in the upper left-hand corner is Sir William Osler. And I think at that time, the idea of going off into your office and thinking deep thoughts and coming up with brilliant ideas worked for a while in the 1800s, but that's not how we do research now, and that's not the best way to do research, which ends up being a partnership between medical colleagues, clinical oncology staff, clinical research staff, our patients, and our supporters. And I think we need all of those people rowing in the same direction to get this as quickly as we can fixed and better than it is right now for our metastatic breast cancer patients. Well, thank you very much for your attention.
Hi, everybody. I'm Missy Van Lokeren, and I'm going to ask the questions from the audience. First, I want to thank both Dr. Anders and Dr. Carey. That was really informative, really good information, and we appreciate it. Real quickly, I am a metastatic breast cancer patient myself. My story is not unlike Pam Cole's that she described earlier. I had invasive lobular cancer when I was 46, had a double mastectomy, and then 4.5 years later, kind of out of the blue, I thought it was in my rearview mirror like she did, I was diagnosed with metastatic breast cancer in my liver. So these talks are so important, and this research is so important, and I can't thank you all enough for all you do. Please use the Q&A button on your app to pose a question, and you can vote for a question you like as well. Just hit the thumbs up button. And also, please refrain from asking specific questions about your treatment. General questions are better. All right, ladies, let's get started. The first question we have is, Natalie asked, can the subtype in brain metastases be different than tumors located elsewhere on the body? What do y'all think?
Sure. So I'm happy to start with that one. So first of all, that's a great question. And I think the answer is yes. We can see differences in the subtype of breast cancer that's in what I would call the extracranial space or below the neck versus what we see in the intracranial space in the brain. And there have been several series of studies that have looked at craniotomy or neurosurgical resections of brain metastasis, which we don't always do in every case. It's actually probably done in the minority of cases, maybe 20%. But in the cases where the patient needed a resection of their brain metastasis, the subtype was compared to those individuals' tumors outside of the CNS. And the subtype differed about 20% of the time, so very similar to what I presented in my presentation, about 15 to 20% of the time. And I think one of the things that has been seen in that space is gain of HER2. So that really opens up some wonderful treatment avenues that may not have been known. I think the challenge is getting that information outside of a brain surgery, which is not a trivial matter. And so I think the next step for us is really trying to figure out how we can determine what that subtype is in the brain metastasis through either the bloodstream or through the fluid around the brain, or maybe even imaging. So I think it's really one of our next challenges and research directions.
And I think the only thing I'd add, and Carrie, has outlined it really beautifully. I do think that finding differences from one metastasis to the other doesn't necessarily mean that their treatment should be different. And so I think this is an area of very active research, including a trial that's being run through the Alliance where they're looking at specifically differences in brain metastasis and seeing whether targeting those, directly, going after those particular abnormalities actually matters within the brain, within the intracranial space, as Carrie called it. So we don't really know how much that matters for treatment of response. It is something that you find, just as I showed, there's differences from one compartment to another. And sometimes that might be meaningful and sometimes it isn't. And that's one of the things we have to find out.
Thank you for that. Amy asked, if you remember, doctors, based on Pam's experience, she shared at the beginning of the program, how does one know when diagnosed at stage 1 that there isn't more disease lurking elsewhere?
Well, I mean, you don't, right? So there's a reason that we treat stage 1 cancers with medical therapy, because remember, the point of medical therapy at the time of diagnosis of a stage 1 cancer is to treat the micrometastatic disease elsewhere in the body. And so, the odds are absolutely in favor of those being, cured and never returning, and increasingly so, right? We're seeing much better outcomes now than even, patients diagnosed now than even a few years ago. But there's no invasive breast cancer that's immune from recurrence. And so, I think we can get smarter. But even, and Pam's story is a great illustration of the places in which our current tools aren't adequate to guarantee that what we have done is adequate and the cancer isn't going to come back.
Thank you very much. Christine asked, how long is one expected to use CDK4/6 inhibitors?
Sure. So we talked a bit about CDK4/6 inhibitors in my presentation, and I have to say they have been a fantastic addition to our toolkit. And I would say in most cases, patients tolerate CDK4/6 inhibitors quite well. My answer to that question more globally is that it's really patient dependent. As long as the patient is benefiting from the therapy from an anti-tumor perspective and tolerating the therapy well so that quality of life is not negatively impacted, I think it goes on as without a expiration date of any type. So I really think it's very patient dependent, and I in my own practice continue it as long as a patient is benefiting and not negatively impacted. Be curious to hear Dr. Carey's.
And they haven't progressed on it.
Correct, right. As long as the disease has not progressed or developed those resistance mechanisms that we discussed. Exactly. Yeah.
Right. We don't actually know if changing to a different CDK4/6 inhibitor or continuing a CDK4/6 inhibitor after the cancer progresses, and if you change the endocrine therapy, for example, we don't actually know if continuing the CDK4/6 inhibitor works. There's some suggestion for the reasons that Carrie outlined that it may not, but there's some studies going on right now to find out. But typically, I think most of us stop for intolerance, as Dr. Anders was mentioning, or upon progression when you move to another kind of therapy.
Thank you for that. Thank you for that answer. Dr. Carey, I think you spoke on this a bit, but I'm going to ask the question Kelly asked. New known mets in one site may not be the same as mets in another. How do you know what treatments to choose if someone is responding well to treatment in one place but progressing in another?
That's a hard one because we have these suggestions that there might be heterogeneity that from one place to another. We don't actually know if that's targetable or if that changing therapy on that basis would work. I have to say my own practice, and it's pretty unusual to see patients with really divergent responses where, clearly working over here and clearly not working there. Usually you'll see, if you see mixed responses, you'll see more regression in one space and stability, or maybe a little bit of progression in another space. And I think I don't typically go after multiple biopsies unless they're really diverging. And then there's an argument to be made that there might be something that you'd want to know about. But it's pretty unconventional. I do think we are more and more realizing that there may be value to biopsying, serially. I think the other opportunity, which is probably what many people do more frequently, is to check for some of those targetable things using the liquid biopsy approach. And we don't actually know if that is going to be helping people to do better, but it is an obvious thing to look for to see if there's something emerging that's different from what it was before.
Yeah, I would just reiterate exactly what Dr. Carey is saying about the liquid biopsy or the circulating tumor DNA that you can obtain through blood, as opposed to going and biopsying multiple different areas. Biopsies are not without side effects or complications, so we don't take them lightly. But I think it is nice to have that tool to get a very detailed vision into the tumor biology from a blood draw. And I think what we don't know is did those tumor cells come from an area in the lung, or did they come from an area in the liver? We can't really identify that yet. But it may give us more information about what's dominating the progression. And so I have started to integrate those into my practice even more than I did probably a year ago. So I think this is relatively new, a new technology.
Thank you for that. This might be a good follow-up question to that. Dolly asked, do you see the breast cancer world progressing to know about the metastases before it actually presents itself?
Ooh.
The short answer, I'll take the first crack at this, Carrie, and you can.
Yeah.
A great question.
Great questions.
Yes, I do think that that we will get better at figuring out relapse earlier, and the only value to that is if you can actually head it off at the pass. And there's this idea of escape from dormancy, where you know, I mean, if you think about it, you know, that patient who had the disease was disease-free for, as far as we can tell, 7 years. And then the cancer started to grow and came back. So what was it doing during those 7 years? So that we know that there is this concept of dormancy. We also know that when we talk about cure, that's a clinical phenomenon, that the patient lives a long, healthy life and the cancer never overtly shows up again, which does not necessarily mean that there aren't cancer cells, but if they're asleep and they stay asleep and the patient lives to 98 and gets, goes out in her own way, having nothing to do with breast cancer, I can make my peace with that. So there's a whole body of research centered on the idea of, are there ways that you can, you know, without treating people chronically, which I don't think anybody really wants to do for obvious reasons, identify patients as the cancer starts to turn back on. Can you figure out what the triggers are, or can you figure out a way of diagnosing that? At the moment, we don't have those tools. We can certainly identify things through, you know, blood tests using tumor markers and doing serial x-rays and scans and things. But when they've done studies to see whether identifying it using those old-fashioned tools helps patients live longer, it does not. So there's not a lot of value to doing it. So we have to get better. We have to get better tools. It is absolutely an area that people are very interested in, and there's a whole lot of research going on. I anticipate that using some of these newer knowledge and analytic tools, we'll be able to do it. But I don't know.
So I think just to add on to that, I think the concept of dormancy is fascinating, and gosh, if we could unlock that with a key, that would be fantastic. I think another strategy that we've seen through some of our partners in the clinical trial space is this concept of patients who have residual disease after chemotherapy in the neoadjuvant setting. So a patient who gets diagnosed with, more of a locally advanced breast cancer, goes through standard preoperative chemotherapy and or targeted therapy, and then still has cancer left in the breast or in the lymph nodes at the time of surgery. And, I think there is a movement to try to understand beyond just ERPR and HER2, which are, of course, very important, but what else might be driving that cancer? And so trying to match the residual disease, which is clearly the most resistant clone, to, maybe endocrine therapy plus something else, or HER2 directed therapy plus something else. So, that study is ongoing. At least it shows that, when there is circulating tumor cells in the bloodstream in that setting, that's a higher risk for recurrence. But I think we need to go one step further, just as Dr. Carey is saying, is identifying the high risk and then matching it to a therapy to try to prevent that recurrence. And I think we're getting there, but we still need some time for that research to mature to know if that's a strategy that we can employ every day.
Thank you so much. I have another question from Teresa. She asks, can local treatments like CyberKnife microwave ablation be used to treat tumors that are not responding to a given treatment when other locations are responding to a given treatment?
Yeah, so maybe I'll start with this one, Dr. Carey. So I think that, I think this is sort of back to that heterogeneity. So one, potentially one area with one clone is progressing. And I think, we don't have a lot of, level 1 evidence as to whether or not we need to treat those, progressing tumors with a CyberKnife or local therapy, even a surgery. But there are some protocols looking at that. It's not correctly the right term, but you might consider this as sort of the oligometastatic disease setting, where there are just a couple areas that have been resistant to therapy, and there have been some protocols looking to see if of those couple areas that have not responded to systemic therapy, could you bring in a local therapy approach to try to determine whether or not that would help the patient in the long run. So again, I think, certainly a strategy that's been used in clinical trials, and I would say in some clinical practice, but I think that data is also really maturing at this point.
Yeah, I struggle with this, and as you can tell, I'm a true believer in the promise of trying to better understand the process of metastasis and what's the differences amongst these things. My own clinical practice is very seldom to take a local approach, simply because of that kind of reason. I think certainly for symptomatic disease where you can actually help the patient's clinical, their quality of life, et cetera. But in my decades of doing this, it's pretty rare that there's a likelihood of a locally directed therapy to provide meaningful benefit when this medical therapy is not working in that site. So it's pretty vanishingly unusual, and usually driven by it being in a place where it's causing complications. That would be my own take. So clinically, I don't think we're quite there yet, except in certain scenarios where there's a clinical benefit to the patient of doing so. And like in the brain, and obviously in the brain, this is the one compartment where we routinely do that, where we treat with local therapies in addition to medical therapy, either before or after.
Right, and that's a great point and distinction, right? So, just as Dr. Carey is saying, is if the tumor is in the brain, given that, that the skull provides such a very confined space, we typically do treat with radiosurgery and sometimes even with resection. Less so whole brain radiation therapy, but it still plays a role. So that would be kind of a unique situation where radiosurgery or local therapy approaches are combined with systemic therapies.
I have another question from Katrina. If a patient is diagnosed with MBC de novo and did not start on the standard course of treatment, what are the next steps if there is progression, and how do you determine a plan B?
So de novo, it's hard to kind of answer that directly because I'm not sure exactly what you mean by not standard therapy. But a couple of things. De novo breast cancer tends to do well, relatively speaking, within a subtype. De novo has a better prognosis than not de novo, and I think we don't actually know why that is, but it's likely that part of it is the acquisition of those resistance mechanisms that, patients who have recurrent disease typically were treated. And so you have a slightly different cancer than, a totally treatment naive tumor that happens to show up and be diagnosed after it's become metastatic. So I think that's been demonstrated. It's been demonstrated in UNC's big database, but in, multiple other databases too. And it does appear to be independent of subtype. There was some question about whether that had related to the kind of cancer. And when we've looked at it in our 1,200 or 1,400 or so patients, it really is an independent phenomenon that relates to having been de novo. And maybe it's resistance, maybe it's something else. We'll find out. I think, depending on whatever a patient starts with, and if they start with something unconventional and it doesn't work, okay, then we, typically I still reach for plan A. If they didn't use plan A in the beginning, I go to plan A second. And it's really based on, what are the drugs that are the most likely to work in this scenario based on clinical research, and overlaid with what are the patient's own personal values and preferences, right? In the metastatic setting, some patients feel very strongly about not losing their hair, and so I'll go down I'll tailor the drugs. I might give up a little bit of likelihood of effectiveness in order to buy the absence of losing your hair. So it's really that's the dance, is between what are the things that have demonstrated effectiveness, what are the likely toxicities, and how does the patient, where does the patient want to meet those in the middle?
I would completely agree. I think, as we're making treatment decisions along the way, we're always looking at, prior exposure, patient preferences, disease status to make that, and now sometimes the sequencing data to make the decision about the next line of therapy. So I think for this particular question, I think it's really looking at what was received in the first line to be able to pivot into the second line.
Thank you so much. Natalie asked, and this is an interesting topic, what are your recommendations for patient resources on what we can do to improve our microenvironment using diet, supplements, and exercise?
Sure. So I think, one is discussion in the clinic with the providers. A lot of the resources that are very important to global health, which I then translate to tolerance to therapies, and we talk about this a lot in my clinic, are right in our cancer centers. So, many cancer centers will have nutritionist folks that can help with dietary choices. Exercise is, I think, particularly in this era when many of us are home quite a bit, is even more important. Just the benefit, the physical and the mental benefit of exercise and being outdoors. I think one of the hard things there is sort of, okay, what does that mean? Does that mean I, take a walk, or do I run, train for a marathon? So, sometimes I will have patients meet with physical therapy or some institutional exercise programs to really help guide them, particularly after therapy, to recondition, if you will. And then in terms of any supplements, I think that many times, depending on the type of supplement or the patient's interest, sometimes involves a referral to integrative medicine. And I think the role there is really to understand the purpose of the supplements, and also importantly, ensuring that there isn't an unknown interaction between the anti-cancer medications and the supplements. We certainly don't want to abrogate the effects of one or the other. So I think, many of the resources are within the clinics and the cancer centers that many folks are going to. And then I think there are certainly resources online. Komen is one, right? Certainly. So I do think discussing the resources with your provider is really important to make certain that the information is adequate, up to date, and really founded in research.
Yeah, and the only thing I'd add, and I think Carrie's 100% right. I mean, most cancer centers have access to, nutritionists. Oftentimes there are exercise, studies and exercise available resources for people who want to do more for their own, good health. Similarly, I think there's a branch of psychiatry that I think is very important. I don't think we should underestimate that having metastatic cancer is hard, and none of us start out with the capacity to manage this effectively. And any way that you can bring people to a place that's healthier psychologically, I think should be done. So I think there's a whole branch of what's called psycho-oncology that I think can be very helpful, and many cancer centers have, kind of inroads. If they don't have their, we have our own branch within psychiatry here, but even, a community practice oftentimes has connections. I think I'm going to say something that I'm going to go back to the original question, which is, can you do something to alter your tumor microenvironment? And I think, we don't know of any way you can alter your tumor microenvironment through something that you do. And I'm going to say something that I feel pretty strongly about. That, there may be people online who disagree with this, but as a treating physician, there are no data that you can manage your body into a form that will fight the cancer better. There just aren't. You can be healthier. You may be able to tolerate the drugs. You may be able to tolerate the cancer. You may be able, just a healthier person. It's better to be a healthier person. But I wouldn't imbue those efforts as having themselves anti-cancer effects, because we have no data that that's true. Moreover, I think it's an unfortunate corollary to that is that if I say to a patient, and it sounds good, like, oh yeah, you should, alter your diet, or you should do this, or you should do that. It's all lifestyle things. It feels good, sort of, because it becomes a partnership. even if I, in my heart of hearts, know there are no actual data that are reliable that this can help as an anti-cancer effect. But somehow now I've made whether the cancer grows or doesn't grow the responsibility of the patient. And I don't think that's fair, and particularly since there are no data that actually can be done. So I think it's a really a slippery slope. It's very feel good, and it's all over the internet and et cetera, but there just aren't any data, right? You know, cancers don't care if you eat sugar or not. Cancers make sugar just fine. They don't, you know, having taken care of a lot of patients at the end of their lives, the cancer's doing just fine even when they stop eating. So, you know, but you know, these things start to become like they take on a life of their own, and I think it's important that we frame this kind of conversation as it's absolutely a wonderful thing to do. I'm 100% in favor of healthy living. I just would stop short of saying you can manage your cancer through your own choices that way.
That's a great answer. Thank you for that. And then this is going to be our final question, and it's from Christine. She was diagnosed a year ago and is curious about her quality of life in the future. What is your basic outcome on this based on your research?
I'm not sure I'm sorry. I'm not sure I quite
I guess her question is, can she have a good quality of life? You know, she was diagnosed with metastatic breast cancer a year ago, and she's worried about her quality of life.
So I'll start with this. I have to say, quality of life, there are two goals of therapy in the metastatic setting: control the cancer and don't make the patient sick, right? So quality of life is one of the key goals of what we're doing. So if we're treating in a way that interferes with quality of life, we're failing one of the two main goals of therapy. So the short answer is yes. You know, if a patient is symptomatic, then the treatment is dedicated to reducing the tumor bulk and helping them to become asymptomatic. If the patient is asymptomatic, then it's around choosing drugs that are most likely to control the cancer and not drugs that are going to make them sick. So that's part of the threading of the needle. So the short answer is yes, and any, you know, oncologists know this. This is what people are dedicated to doing.
Yeah, I would completely agree. You know, I think I view my job to not make the patient feel worse than the cancer is, right? I would never want my therapy in the metastatic setting to cause worse symptoms or worsening symptoms than the cancer is causing. And therefore, there's always this careful tailoring of the choices. This is why every patient is so individual, right? They present with different symptoms, they present with different background, they present with different health or background in terms of therapies, they present with different health, you know, global health walking in the door, and they have very different goals. And so all of those discussions are part of the decision for what the best next therapy is. And, you know, I think just as Dr. Carey said earlier, you know, some patients are very interested in trying to be out of the infusion room and would much rather, you know, pursue an oral therapy, and that's very important to them. You know, other patients may feel very uncomfortable taking oral therapies at home and enjoy the camaraderie of the infusion center with other patients that they meet along the way. You know, I think, you know, these are all pieces of the puzzle in the goal to ensure that the life is a wonderful quality. And I think that's, you know, I know Dr. Carey feels the same way. Like that is our job, is to try to really ensure that you're all living well. So, and that's a partnership, right? Like what I say doesn't, you know, it really doesn't matter. I can give advice, but it's really individual to each patient. And I think that's why the conversations are so important with your oncologists, to make certain that you're making those right decisions for you together.
Well, I think that's a great note to end on. Thank you both so much for joining us. Dr. Anders, Dr. Carey, we really appreciate your time. It was really a joy to have you today. Thank you so much.
Thank you very much.
Such a pleasure. Thank you so much.
Thank you, Dr. Carey and Dr. Anders, for sharing your expertise with you. Wow, it's just so amazing to hear the amazing work that you're doing. Your work inspires all of us living with metastatic breast cancer, including Missy and myself. What you do gives us hope every single day. It's the work being done by these researchers and their colleagues at UNC and Duke that led our Komen, North Carolina Triangle to the Coast affiliate to launch a first-of-its-kind fund to foster collaboration between these institutions and to fast-track innovation toward finding the cures to MBC. The Metastatic Breast Cancer Collaborative Research Initiative will fund research projects where UNC and Duke researchers work together, and our goal is to award the first grant funding in 2021. Visit KomenNCTC.org to learn more about this innovative opportunity to find breakthrough treatments and cures for metastatic breast cancer. Thank you again, Dr. Carey and Dr. Anders, for presenting today, to Missy Van Lorken for moderating the question and answer, to Patty Spears, an advocate in science here in the Triangle, who will post the answers to the live questions shortly in the chat area, and to our full planning committee of volunteers that helped shape today's session. On behalf of Komen, North Carolina Triangle to the Coast, thanks for spending part of your day with us and engaging in these very important discussions on MBC research. And this concludes the program today.